From the American Neurological Association, I'm Adeline Goss. This is ANA Investigates. Today we'll focus on new onset refractory status epilepticus, or NORSE, and its closely related presentation, febrile infection-related epilepsy syndrome known as FIRES. NORSE and FIRES are clinical presentations where the evidence is limited, stakes are high, and treatment often has to begin before the diagnosis is clear. They also raise broader questions about how neurology can respond to rare but catastrophic illness, including how patients, families, and researchers can work together to move the field forward. For an update on NORSE and FIRES, we spoke with Dr. Howard Goodkin and Dr. Larry Hirsch. Dr. Goodkin is the Shure Professor of Neurology and Pediatrics at University of Virginia. Dr. Larry Hirsch is a professor of neurology at Yale University. They were interviewed by Dr. Ifrah Zawar, Assistant Professor of Neurology at the University of Virginia. Here's Ifrah.
Howard and Larry, we are truly honored to have you here with us today, two pioneers in the field of status epilepticus.
Good morning, Ifrah. I'm excited to be here with you and Larry.
Thanks for having me. I'm excited about the upcoming conversation.
Thank you. So, Howard, to start, can you help us understand what NORSE is and how it differs from FIRES?
Thanks, Ifrah. Good opening question. And I think from the get-go, I want to make sure that everybody understands that NORSE, or new onset refractory status epilepticus, is a clinical presentation. It is not a diagnosis. NORSE refers to refractory status epilepticus that failed to respond to first-line and second-line anti-seizure medications in a patient without a prior epilepsy diagnosis and without an immediate identifiable acute cause, such as a stroke, infection, or a toxic metabolic insult. Key features to remember are that it can occur at any age. It frequently follows a viral-like prodrome, but an etiology is often not identified, and that many cases are ultimately presumed to be immune-mediated or inflammatory, even when antibody testing is negative. Now, FIRES, what I deal with mostly as a pediatric epileptologist, FIRES, or febrile infection-related epilepsy syndrome, is a subtype of NORSE, which occurs in a previously healthy child or adult and is associated with a febrile illness that occurred days to weeks before the explosive onset of the refractory or super refractory status epilepticus. In short, all FIRES is NORSE, but not all NORSE is FIRES. The etiology is often elusive with no clear cause identified in up to 50% of cases, and standard autoimmune panels are frequently negative. NORSE has forced us to evolve in how we treat these cases of refractory status epilepticus to include targeted cytokine modulation such as interleukin-1, IL-1, and IL-6 blockade. For me, a frustration is that the outcomes, despite optimal care, are frequently devastating, with many survivors developing chronic drug-resistant epilepsy with cognitive, behavioral, and psychological sequelae being quite common.
Which makes it very important, and that is a great summary and introduction. Larry, what first brought you to this area of research?
Well, it's really a combination of things. One was for anyone who's taking care of one of these patients, these are very difficult, prolonged, memorable, and disturbing cases. It's day after day of refractory status that really seems like it's not responding to your efforts many of the time. So they're very memorable, and you really are searching for something to do and a way to understand how this totally healthy person suddenly ended up in the hospital in this refractory status condition. So that's the main thing, is I had a couple experiences like that. And the other part that drew me more from a research standpoint was that there's really no hint of how to treat these people or any specific treatment at all. For me, when I was starting to do this, there was no name. Even the term NORSE wasn't really used. It was called all kinds of things. I think there were 10 or 15 different names in the literature, and the pediatric literature was different than the adult literature for the exact same presentation. So that was one of the first things we did is come up with some consensus diagnosis and terminology now about 8 years ago. And then finally, I was contacted by Nora Wong, who had lost her son to NORSE and was looking to do something about it, find out what happened and get some research into it. And that eventually led to the creation of the NORSE Institute, for which she's the executive director.
So that is truly inspiring. And I'm really glad you've made all of this effort in this really important yet understudied area. So, turning my attention back to Harvard, in your clinical work and research, what has surprised you the most about NORSE and FIRES?
Yeah, partially what Larry said, these cases are hard to care for. You're going to the bedside every day. Parents and family members are looking at you, looking for an answer of when the seizure is going to stop and why did it happen? How did this previously stable brain from childhood to adult enter this state of self-sustaining treatment-resistant seizures so abruptly without a clear precipitant, without a lesion, without an obvious pathogen, toxin. The brain behaves as though it has suffered this massive insult, yet there's no macroscopic injury to explain what's going on. And it's that absence of obvious factor or cause that has surprised me the most about NORSE and FIRES.
And like both of you said, it is truly devastating and life-changing both for families and the patient. So I'm really excited to mention a landmark trial, perhaps the largest NORSE trial to date that Larry just started doing, and the only prospective randomized clinical trial. So Larry, this trial is a major effort to systematically address these syndromes. What motivated this particular study design?
Thanks, Ifrah. Yeah, so it's really years in the making. So for the past 8 years or so, we've had a prospective observational study with biobanking, where we take samples and clinical data from cases around the world. For 20-something centers, we have very detailed data and IRBs, and then for anywhere else in the world, we can do it directly through Yale consent, and we get some clinical data, not as much, and we get samples whenever it's financially feasible. But from doing that, we have more than 150 patients biobanked with pretty thorough information. And one of the most important things we learned, as Howard alluded to earlier, is the role of inflammation, specifically the innate immune system with IL-1, IL-6, IL-8, and some other markers being markedly elevated in NORSE patients, even more so than other refractory status epilepticus patients. And that the inflammation seems to be important. Number one, it correlates with seizure burden around the time it's drawn. And it also correlates with long-term outcomes, so months after they leave the hospital, and they're independent predictors of that. And there have been several small series that suggest that immune treatments help, and that the earlier you give them, the more likely it is to help. So the most commonly used agents are anakinra, an IL-1 blocker, and tocilizumab, an IL-6 blocker. And the consensus statement that we put out for managing NORSE suggests at day 7 for cryptogenic NORSE to give either anakinra or tocilizumab, and there's no way to choose which one of those to give. So the upcoming trial we have, I'll tell you more about in a moment, but basically does that. It makes that decision for you and randomize patients to anakinra or tocilizumab for cryptogenic NORSE at day 7. So the study is funded by PCORI, the Patient-Centered Outcome Research Institute. I have 3 fantastic co-PIs. So Dr. Margaret Gopal is really key in getting this award in the first place and running almost everything with me. And then Dr. Nora Wong, executive director of the NORSE Institute, is key in the patient engagement portion and the patient family advisory board. And we have Dr. Krista Eschbach, a pediatric epileptologist in Colorado, who is also one of the co-PIs, and she's running the qualitative interview portion of it. So we're just getting started on that. So you'll have to have me back in about 5 years to give you complete results of it.
That sounds great. Could you also tell us a little bit about the primary and secondary endpoints of your trial?
Sure. So the primary outcome will be at 1 year, and it's a functional outcome scale. It's the Glasgow Outcome Scale extended version. And then secondary outcomes, we have several. It's time to resolution of status epilepticus, hospital length of stay, mortality, serious adverse events, post-NORSE epilepsy, and then we have a combined measure called treatment success, which means a lack of need for any other immunomodulator and good outcome at 1 year. And then we have many tertiary outcomes, and a lot of these were chosen by our patient family advisory board about things that are important to them and that are not measured by standard scales. Lastly, we have extensive qualitative interviews for a subset, which will be about 125 subjects. We'll have very detailed interviews about what it's like living after NORSE in the chronic stage. And I should mention the sample size, we're aiming to randomize over 300 patients. There's 33 centers involved. It's an international trial. And then we will also have an observational arm for patients who cannot be randomized by day 7.
That sounds amazing. That is an extremely well thought out study. And I think what I really like about this study is obviously it's the largest of its kind, like I mentioned earlier, but I really like that it's truly patient centered. So, in addition to your study, are there any other recent advances in the field you want to tell us about?
Yes, since we're pretty early in understanding this disorder, there's extensive research going on, a lot of it using the samples we've been biobanking for the past 8 years or so. There seem to be different patterns of inflammation within the cryptogenic NORSE group. So some of them just have the classic mark elevation of the innate immune markers that I mentioned. That's kind of the classic NORSE profile. And for those, probably tocilizumab or anakinra are the best options. There is a subgroup of older patients who have no significant inflammation, and perhaps in those people, giving immunomodulation is not helpful. And then lastly, there's another group that seem to have a form of inflammation that is more similar to patients who have autoimmune disorders, including activation of JAK-STAT pathways and more T-cell markers. And that suggests maybe in that subgroup, they would respond better to something like rituximab or Cytoxan, or even the newer JAK inhibitors. Most of those, there are case reports out there already. So I think we have a long way to go. Since it's a clinical presentation, there is significant heterogeneity, and hopefully we can personalize treatment eventually. As far as treatments, there's been several reports of intrathecal steroids working, and so far nobody's reported any complication from that. It seems to be a very safe option to try. Other really interesting research going on. There's some basic science models where people are trying to recreate the post-infectious condition. For example, there's one with slices that are exposed to lipopolysaccharide, and it really mimics the virus condition in that it leads to marked inflammation, more hyperexcitability, refractoriness to standard anti-seizure medications, and response to immunomodulation. So hopefully these kinds of things can be used to screen treatments or come up with things to study clinically. One of the things we've become more interested in, and the Patient Family Advisory Board has really pushed, is studying the chronic phase for people who are months and years out, and see whether there's still inflammation going on or not. So far, most of our studies have shown there's not much, at least not the same innate immunity markers. But some studies have shown that there's progressive brain atrophy that still happens months to years out, even in patients who seem to be doing okay. And it's not yet clear how much prognostic utility that has, but it suggests there might be some ongoing process, perhaps even neurodegenerative in some cases. There are very interesting studies on the microbiome have been published recently, showing that NORSE patients seem to have a different microbiome even than patients with other forms of status epilepticus, and both of them are markedly different than patients with chronic epilepsy. And some of those changes from our studies and from a lot of other literature show the microbiome correlates with inflammatory markers and may be causal. Lastly, I guess I'll mention there have been several reports of neuromodulation, mostly vagus nerve stimulator, but a few with other types of stimulators, including direct brain stimulation, not only chronically for post-NORSE epilepsy, but also in the acute phase, with the vagus nerve stimulators seem to work in several cases. So there's some studies going on with that as well. There's more, but for the sake of time, I'll stop there.
No, that's all wonderful. I feel like I've learned so much about the latest research in NORSE and FIRES today, and I'm really excited about the progress we are making in the field. So, switching back my attention to Howard now, as a basic science research, would you like to add anything about the underlying mechanisms of NORSE and FIRES in addition to what we have already learned today?
I think it's fair to say we're still very early in this journey, but we're making progress. And as we've talked today and repeating, the critical thing here is that what we do know, I think, is that this is a cytokine dependent network phenomena. And it's not just electrical failure, but that this inflammatory innate immunity response that is maladaptive to the initial injury seems to be critical here. And so there's still much work to be done, but at least we have a path or a way forward of better understanding basic mechanisms. Before I turn it back to you, Ifrah, though, I think Nora Wong and the Norse Institute deserve much more than just a passing mention in this. And I would suggest if somebody has not been to the Norse Institute website, they will find a plethora of informative material. And for the clinician who is faced with one of these conditions, the consensus statement and thoughts about how to proceed are all there. Just well worth your 5 minutes to go to that website.
Without question, I agree with everything you said. Norse Institute is an amazing and a huge effort. And recently I had the opportunity to help out a family in UK with their daughter developed Norse, and I shared a lot of resources from the Norse Institute, and I think they are very much engaged with that. And I think it's, like you said, it's not just for the clinicians. It is very user friendly and easy to access even for the patient's family, which makes a huge difference. So my last question is from both of you. Looking ahead beyond this study and other ongoing studies, what do you see as the next steps for research in Norse and fires? Where do you think we go from here?
I think getting more comfortable with using these drugs that we've not used previously in as neurologists, but are using more and more in treatment of status. There was a period where there was active research and thoughts about uh, treating the inflammasome and epilepsy. And I could see where Larry will inform treatment not only of status, but maybe in epilepsy as well. And I only see excitement here as an avenue of research across all stages of our understanding of basic mechanisms of seizures and epilepsy.
Thank you, Howard. Larry, anything you want to add to where do we go from here?
Sure. I think what Howard said about how it relates to other forms of chronic epilepsy is really important and something to look at. I didn't mention genetics much, but we have learned some from genetics, including polygenic scores. And there were some interesting papers came out showing that patients with Norse have these high polygenic scores related to other inflammatory disorders, particularly ITP and idiopathic pulmonary fibrosis, and that those actually correlated with things like the Claustrum sign and other markers. So very interesting, more complicated genetic analyses. There's many other aspects of inflammation that haven't been studied much. I'm not an inflammatory expert, but I'm learning about all of it now. And things like the complement and the role of microbiome, I think, are fascinating and just getting started. There's some interesting things with proteomics coming out. Investigation into the triggers and how this routine viral illness can trigger this, and perhaps it's related to the actual virus and genetic predisposition, or a combination of those. I think the collaborative research we're doing is really the only way to approach all this, and that's moving along. And hopefully we can set it up to do multiple back-to-back trials, kind of platform trial type of studies. So stay tuned. Just if anyone has an acute case and they want to potentially send samples, enroll the patient, or just get advice on it, you can contact us at a very simple email of norse@yale.edu.
Yep. Thank you so much for doing all of that work and all the ideas for future research. It was truly a pleasure to have you here today.
Well, thanks for inviting me.
Ifrah, you did too good of a job. They're going to invite you back and back and back.
Thank you so much.
That was Dr. Larry Hirsch of Yale University and Dr. Howard Goodkin of the University of Virginia, interviewed by Dr. Ifrah Zawar of the University of Virginia. ANA Investigates is the official podcast of the American Neurological Association. The show's producers are members of the ANA Education Innovation Committee, chaired by Sarah Nelson and Sharon Ellen Govan. I'm Adeline Goss, podcast host and executive producer. Our production team this month included Ifrah Zawar and Jen Hurley. You can listen to past episodes of the show, subscribe to us so you never miss an episode, and access all of the ANA's educational programs on the Education tab at myana.org. That's it for ANA Investigates. See you next month.